Miliary tuberculosis, a clinical perspective. So, I will be discussing miliary tuberculosis, a rare but life-threatening manifestation of tuberculosis that occurs due to hematogenous dissemination or spreading of Mycobacterium. The condition is called miliary because of its characteristic appearance on chest radiograph, resembling like a millet seed. So, in a definition and pathogenesis, miliary TB result from widespread hematogenous spread of TB bacilli from a primary or reactivated focus. The dissemination can occur in first in a acute fulminant form, that is the septicemia like presentation. Second is a subacute or chronic form, which is slowly or progressive disease. Common risk factors are: first is a immunosuppression like HIV, AIDS, severe uncontrolled diabetes, malignancy, chronic kidney diseases, elderly and malnourished patients, patient using corticosteroid for a long time, or immunosuppressive therapy. So the clinical features in miliary tuberculosis is multiple organ system involvement, making the diagnosis challenging. Common symptoms include prolonged fever, night sweat, weight loss, anorexia. These are systemic symptoms. Now in respiratory symptom, cough with or without expectorant, breathlessness, ARDS in severe cases. In neurological symptoms like TB meningitis, altered mental status. In gastrointestinal, hepatosplenomegaly, abdominal pain, diarrhea. In ophthalmic, there is a choroidal tuberculosis, a pathognomic sign of tuberculosis. Hematological, there could be pancytopenia due to bone marrow involvement. So the diagnosis, miliary TB remains a diagnostic challenge due to its diverse presentation. Key investigation includes laboratory tests like CBC, in which anemia, leukopenia, thrombocytopenia, increased ESR, CRP usually increase, LFT, liver function test, elevated transaminase in hepatic environment. Blood culture may be positive for Mycobacterium tuberculosis in 10% patients. Radiological investigation, X-ray chest, classically it will be seen as a millet seeds which are 2 mm nodules diffusely spread in both lungs. HRCT, better sensitivity, showing randomly distributed nodules. MRI brain, if neurological symptoms are present, to detect TB meningitis. Microbiological and histopathological tests, sputum or bronchoalveolar lavage, gene expert to detect MTB and referral blood, CSF, urine, gene expert in disseminated cases, liver biopsy, bone marrow biopsy for granuloma if other tests are inconclusive. So, in differential diagnosis, miliary TB can mimic several other diseases, and ruling out other condition is crucial. Infectious causes like disseminated fungal infection, histoplasmosis, cryptococcosis, candidiasis, differentiated by fungal stain or culture. Brucellosis, which is associated with occupational exposure, serology positive. Leptospirosis, which can show conjunctival suffusion, renal involvement. Leishmaniasis, that is a Kala Azar, which shows hepatosplenomegaly, positive RK39 test. And now in malignancies, lymphoma, that is a Hodgkin's and non-Hodgkin, which can show lymphadenopathy, atypical cell in biopsy, metastatic carcinoma, which shows primary tumor evidence, positive tumor markers, hemophagocytic lymphohistiocytosis, that is HLH, cytopenia, high ferritin, autoimmune and inflammatory conditions. First is a sarcoidosis, which is non-caseating granuloma, acetylcysteine enzyme, that is ACA level high, no Mycobacterium is seen. In disseminated lupus, that is SLE with MAS, ANA plus DS DNA positivity. In venous granulomatosis, the granulomatosis with polyanginitis, CANCA positivity. Now in management, anti-TB therapy, standard 6-month regime in which intensive phase of 2 months, which contains isoniazid, rifampicin, pyrazinamide and ethambutol. And in continuation phase, which is of 4 months, isoniazid, rifampicin and ethambutol. In longer treatment, that is 9 to 12 months, required in central nervous system involvement. Miliary TB with bone involvement or immunosuppressive patient. Steroid like prednisolone 40 to 60 mg per day in TB meningitis, ARDS or adrenal involvement. So now in supportive care, oxygen therapy in hypoxic patient, nutritional support, treatment of underlying immunosuppressive conditions, monitoring and follow-up. Repeat X-ray chest after 2 months to assess response. LFT for hepatotoxicity monitoring, liver function test for hepatotoxicity monitoring, therapeutic drug monitoring. If there is a treatment failure or drug resistance. Conclusion: Miliary TB is a serious but treatable condition if diagnosed early due to its non-specific symptoms and broad differential diagnosis. A high index of suspicion is essential. Early initiation of anti-TB treatment and supportive care significantly improve outcome. Thank you.